So welcome back to the latest episode of Taking Charge of My Cancer podcast. And I have a very special guest today. This is Emily Bell. So Emily is a physical therapist who works in outpatient oncology rehab clinic in Colorado. She graduated with her bachelor's in Applied Physiology and Kinesiology from the University of Florida and her doctorate of physical therapy from the University of Miami. Additionally, she's certified lymphedema therapist, certified in dry needling, and a PORi certified oncology rehabilitation specialist. Emily treats all types of cancer patients for functional pain and lymphedema-related deficits. She is a proponent of PT through the cancer care continuum in order to optimize quality of life and mitigate the severity of functional impairments when possible. So, Emily, it's a pleasure to have you here, and thank you for doing this with me.
Of course, it's a pleasure to be here.
Excellent. So Emily and I always tell your story because for my students, so Emily came as my student around COVID time.
Yep.
Yeah, and so she, again, University of Miami usually have like an 8-week internship. And that was another student, ex-student, so he's a PT now as well in oncology. His name is Shai. Actually, Emily knew about the possibility to turn her internship from 8 weeks into 16 weeks to do oncology with me because Shai did that. And then University of Miami really never did that until I guess Shai asked them, can I do this? Because this is what I want to do. And I guess that's how you find about the internship with me. And that was the whole point, was for you to spend 16 weeks with me and learn everything possible about oncology. She comes to me super excited. And she's like, I put up with a lot of things and I didn't care other internships as long as I was able to do this with you. And literally, like maybe 3 weeks in,
Yeah, I think it lasted about 3 weeks.
3 weeks in, COVID happens and the clinic shut down. I mean, the schools, first thing that happened was the schools just pulled all the students like 1 day notice.
Yep.
Uh,
It was
so
like I left one day and I got a phone call that night. It was crazy.
that was crazy. I cannot come back tomorrow. And I'm like, well, you kind of have to come back to finish your documentation before you leave. And then that was it. And so I felt so bad because I know that's what you want to do. You even told me we thought that was going to be just a temporary thing, a few weeks. And it's like, can I come back? And I'm like, absolutely, you can come back. And you were like, even contemplated to move graduation away a little bit if that was an option. And it's like, I'm here for you whenever you want to come back. But of course, it's not realistic. So in the 3 weeks that she did with me, she did a fantastic job. When something is your passion to the point that that's all she's been doing, I guess, but you're going to tell us more about it since you graduate. It's going to be really involved with oncology. Um, so when I was looking for I thought about you being a guest on the podcast because you can really bring a lot of some information, or what is it that drive you into oncology? Why, how can you maybe inspire other students who wants to do this, and then maybe follow your path. So
Yeah.
that's kind of like how we met each other. So you want to tell me a little bit about your mission and where you always planning to do this?
So I think my mission is probably similar to a lot of other people in our field. And really that's just that I want to help people feel better. I want to help them have a better quality of life. We know so much how much cancer takes a toll on the body. It's brutal what some of the cancers themselves and also their treatments do, and it really impacts people's like long-term quality of life after maybe they finished all their cancer treatment. And I just want to help them feel better. In terms of why oncology, or did I always know I wanted to do oncology? Long and short, sort of, kind of, but not really. I figured it out during PT school. So I went into PT school. I had shadowed, oncology and stuff. So I was kind of exposed to the idea. But really, what I knew I wanted to do was find a specialty that needed more therapists to do it. So there's not that many oncology therapists out there. So I know I wanted to find a specialty that was like needed. And then on top of that, I wanted to find a specialty that I got to use pretty much everything I learned in PT school. You take ortho classes, you take cardiopulmonary classes, you take neuro classes, you go through it all, and then a lot of people kind of niche into one little market, and that's sort of all they do. I think oncology is kind of a special little realm in that with cancer patients, you sort of have to not just know oncology, but know all the rest of it. I'm using ortho skills all the time when I'm doing manual therapy and people have joint pains, muscle pains, and whatnot after their cancer treatments. I'm using neuro skills when I'm treating chemo-induced neuropathies or vestibular problems, or, you know, there's also brain tumors out there. There's, you know, a lot of neuro skills involved. I teach respiratory muscle training when I have lung cancer patients. I teach lymphedema and skin care and integumentary stuff when patients have lymphedema deficits. So you sort of go all over the place, and it can be really interesting. And I feel like these patients really, really need us. So that was kind of how I became interested in it. And then honestly, even though I was only with you for like 3 weeks, it sort of solidified that feeling for me. The patients are just really great. They're really, really appreciative. It feels amazing to help somebody kind of get their life back, even if it's not necessarily the same as it was before. Sometimes it is. Help them feel a little bit more human again. And I think it's cool.
Excellent. Very good. What good resources would you advise oncology patients to look into it? So if you have somebody who, you know, you have a patient who comes to you with a diagnosis of cancer and they're like, you know, man, I just got this diagnosis. I just see the surgeon, I'm gonna have breast surgery or I'm gonna have head and neck surgery or whatever it is, or chemo or radiation. And I really, how can I get more information about my kind of cancer? What would you advise them?
So this is definitely a common question out there, right? Because you get diagnosed with something so life-changing and you're like, I want to know all of the things. And honestly, I would also want to know all of the things. Like it's very natural. I think sometimes people get a little bit too lost in the Google weeds. You can end up finding incorrect and or just overwhelming or not related to necessarily the same things that your particular cancer is related to, because you know there's all the different stages and then the different subtypes, and I think it can get a little bit overwhelming for people. So typically my most simple recommendation is actually to use the NCCN handouts, so the National Comprehensive Cancer Network. That's the guidelines that pretty much all of the physicians in the US will utilize to, you know, choose like what treatments and everything that each patient needs. So they actually make patient handouts. So if you go onto the NCCN website, they have those handouts for each type of cancer, and some of them are kind of lengthy packets, but they go into pretty good detail about, you know, each of the treatments and kind of what to expect and what your staging means sometimes and stuff like that. And it's at least from a reputable source and hopefully related. So if somebody's wanting to like read a lot more than rather than what they've just kind of found out resources from their personal oncology team, that's usually somewhere that I direct them.
Yeah, that's a great idea. And you mentioned something important, you know, now everything is just easy to Google. And then Dr. Google, unfortunately, doesn't give you the best information, like general does, but sometimes can be really scary and really
Yeah.
misconducted to where you want to learn from. So definitely look into that or any good resources. A lot of the places, a lot of your surgeons, a lot of your medical oncologists will give you other links that are actually research based
Mm-hmm.
Medical base, that's where you want to try to get your information from for the
Yes.
most part. So do you have any three valuable tips that you have that could benefit my audience? And then audience at this point, because I'm going to divide it in two, right? I'm going to say audience, oncology patients or patients with cancer and caregivers. And the
Okay.
other audience is going to be students who are
Okay.
going through PTA school or DPT and then wanted to pursue some of oncology. So let's start with the patients that are dealing with cancer.
All right. So my advice for patients, whether they're undergoing cancer treatment or maybe recently finished cancer treatment, or maybe they're years out from their cancer treatment, is, as hard as it sounds, try not to get too frustrated with your own body.
Very
I
good.
know that's a hard ask. It's a really hard ask because it's annoying when your body starts to not cooperate or do what you want it to do. But that being said, I think it's good to give yourself some grace. Your body has gone through a lot, and a lot of these cancer treatments actually sort of have ongoing development long after you're done with treatment. So, like radiation, the fibrosis can develop for years. Sometimes you're on long-term medications for treating the cancer and preventing it from coming back. So it's not like your anatomy is 100% the same, your physiology is 100% the same. It's a lot different. So I'd say take a step back, try not to get too frustrated, and instead try to learn your new body.
Mm-hmm.
So if you take the time to, with hopefully a PT, kind of learn your new body and what it needs to feel good, honestly, you can go a lot farther rather than trying to fight it to be what it used to be. Is kind of what I think there, because your anatomy is different, your physiology is different. If you just take the time to kind of learn your new self and what your body needs now to feel good, you might get back into all of the same stuff, but maybe it's just a little different how you do it, or maybe you need to do X, Y, and Z first to feel good, and everything like that. And maybe it's not the same, but it's still awesome.
Yeah, that's a great advice. That's a very good way to see it. How about for students?
So my tip for students was be willing to adapt constantly. So I think the most interesting and challenging part about working in oncology in particular is that our patients are pretty much always constantly changing status. We see a lot of people during active treatment or within, the shorter timeline once they're done with treatment. So there's a lot of fluctuations going on. There's a surgery here, they started chemo there. This develops here, and it just changes a lot. So that being said, you kind of need to treat every single visit with them like a little miniature reevaluation. So that was something I kind of did with you too. It's like treat them how you see them today. So when they come in, it's maybe a completely different issue that they're talking about than the time prior, and that's okay. You have to be willing to adapt and kind of do a little mini reeval, figure out what's going on right now, and help them with that. So I think that can be a little overwhelming for students when they're entering this particular specialty, just because it's so much of what we consider the high complexity patients, and high complexity simply meaning that they status changes a lot. So it's not that clear linear trajectory of improvement that you see all the time. It's one thing's getting better, another thing maybe pops up, and you kind of work with what you've got at every time and just helping the patient feel better.
Yeah, that's a very good point. And sometimes is that I'm trying to really, hopefully, I think a lot of some of the schools are really hopefully during their program to really improving the amount of oncology that they're teaching the students. And I understand that you cannot learn every specialty during PTA school, like you cannot do that during medical school, but I think it's really turning more into a huge need for students, because even if you go into an ortho internship, right, and you have, oh, sorry, into an ortho practice, and you have this amount of survivors that are really, we're getting more and more now because we've been, better about treating cancer and patients are lasting longer. And then you have all these other sequelas from treatment that, yes, that patient can be coming to you for the shoulder, but they have all this history behind and some of the things that can be happened to them that was due to the radiation or due to the chemotherapy, that if you're not aware of that, you will never think of those that. And then you're still thinking about like, oh, this is just a shoulder impingement or whatever. And it is no cording. Has nothing to do with radiation fibrosis, doesn't have to do anything with other treatments that they have in the past. So I think that that's important for some of the PT schools now to start to really looking at giving more information and tools to the students to have a little bit more baseline knowledge than just a one simple lecture.
Yeah, I agree. I think a lot of the schools are starting to get better at that, which I think is amazing. I've noticed that some more with some of the recent students that I've taken on, which has been cool. When PT became a doctoring level degree, they talked about one of the main reasons that it became a doctoring level degree is that we need to know differential diagnosis, meaning that when a patient walks in, we need to be able to be the ones to do the evaluation to figure out what the issue is of what's going on. And if it's not something that we can treat, at least know who to send them to or to send back to their physician, right? And I think a lot of times with these oncology patients, there wasn't enough groundwork in the schools to actually have the PTs be able to adequately do that for them. A patient might come in with a shoulder pain that had a history of breast cancer, but the PT didn't understand, cording. They didn't understand radiation fibrosis. They didn't understand lymphedema. They had like 1-2 hour lecture one day, kind of grazing the surface on all that, but not really how to check for any of that or to know if it's involved. And I think they are getting a lot better at that nowadays. And the internships always help if you manage to find one in that specialty too.
Absolutely, that makes a big difference. As you already know, my philosophy with all the students who come to me is like, I want to turn them into oncology specialists. That's my mission, I say to them in the first day. And then they're like, yeah, right. And then actually, I've been really converting a lot of people. They come with the idea to go to ortho or neuro, and they're like, really, if I don't convert them, at least I know I'm planting that seed in their heart. And they always looking for like, well, yeah, I'm still wanted to do sports medicine, but I won't mind at all to do oncology because I don't
Yep.
think I came across anybody who does not like it. And I think it's because how great the patients are and how grateful the
So
patients
great. So great.
are. Yeah, yes. All right. How about any painful lesson that you learn along your journey?
um, so painful, I don't know. I feel like that's kind of a harsh word. um, Lesson that I feel like I really gained a lot from learning is that it's not bad to ask for help or for another person's opinion. I think in general, I always grew up as a little bit of a perfectionist, which I think a lot of people do. It's not really too out of the ordinary. But that being said, I think a lot of people think that if you're a clinician and you have to ask for another therapist's opinion or anything like that, that they failed or stuff like that. A lot of other professions do ask other people's opinions as kind of standard practice. It's sort of just the norm, it's expected. Like tumor boards, tumor conferences are literally set up in place as scheduled regular meetings where the entire oncology team meets up and just asks each other's opinions and make sure that they're all on the same page and doing the right thing, and not just doing the right thing, but doing everything that can be done. And I think sometimes I would be like, yeah, I'm totally cool asking other people's opinion, but only once I get stuck. And it's like, you don't have to necessarily do it when you get stuck. I think it's
Yeah.
the more you collaborate along the way, it just gives you so much more knowledge. You're seeing different viewpoints and you're doing better, I think, for your patients. So I don't see it as a bad thing anymore. I don't see it as a failure. I see it more as you doing the most you can for
Yeah.
your patients along the way. And so if you've got coworkers who want to pick their brains, that's great. If you don't really have other coworkers in that specialty that you can ask, APT Oncology has a lot of opportunities to connect with other clinicians. They're like mentorship programs and their online listservs and things like that, where you can ask questions if you don't have anyone around you. So I think those sort of things can be really, really helpful.
And you brought a really good point. At one point during my career, and I used to do orthopedics for years before I did oncology. And I remember being upset with one of the physicians that I work in a clinic, a private practice I work at, where I was asking, like, the patient needed to go to a specialty, an ortho specialty for whatever he was having. And the physician was upset because I suggest that to the patient. And I was like, are you serious? Like, you are an internal medicine doc, or no, he was actually a primary care physician doc. This is not your specialty. That's why it's a specialties. And if you feel you know it all, that's not a good thing. So
No, it's
I say,
not. Nobody knows everything. It's
exactly.
impossible.
I, I say to my patient, if I'll be you, you should maybe change primary care. I think you should be able to go. If you have any physician out there, doesn't matter what the specialty, and they feel uncomfortable for you to get in a second opinion, that is an indication that you better be changing for another physician. Because as much as I know the greatest physician, always encourage you to go to get multiple opinions if you wanted to, because
Yes.
you want to know what is, they want you to feel comfortable for with your physician or whatever you feel that you need, right? So
Mhm.
I always say that. So same thing here in PT, right? You don't know it all, and you need to be able to refer out to somebody or bring somebody, no matter how much experience and what a senior therapist you are. But you can even I get great information from students all the time.
Me too. I agree.
Learn
It's
so much
sometimes it's
because
just nice to brainstorm with somebody else.
exactly. Great new ideas always is welcome. And then you just apply that, right? So,
Mhm.
so that's a very good point. Um, how about how do you how do you advocate within your company for patients to be sent earlier on to therapy?
So that is one that I think is not just me. I'll say it's kind of my whole team. We've sort of done this as a collaboration effort, and I think it's been working pretty well so far. So we have actually made a lot of handouts, and I almost actually stole this from when I worked in your clinic because you had like so many handouts for your patients, and I thought that that was amazing. So we've made not only handouts for patients, but handouts for physicians to give to patients in their offices about us, because a lot of the time, I think the patients are maybe told or offered therapy services, but don't fully understand what we do. And they're really spending those visits with their oncologists, their surgeons, trying to figure out what's going on with their cancer treatment, right? And I think that's important. There's so much information, they're overwhelmed. So even if the surgeon or anybody else that they're meeting with does an excellent job of explaining why they need to come to therapy, they might not remember it, or they might just be too overwhelmed. So having that handout to go home with and kind of look at it later, I have found has really helped. So I made some handouts and then actually brought them to the tumor boards. So I brought them to the tumor board I'm a part of, and then some of my other coworkers gave them to other tumor boards that they're a part of and presented them to the physicians and be like, if you'd like to give your patients something so that they understand why they're being sent here, this is like an easy way to do that. And we saw like a dramatic increase in the people kind of accepting the referrals, and also the physicians remembering to send people kind of early on, and get those people maybe pre-op or prehab or while they're still in active treatment so that we can be not only helping them feel good once there are problems, but maybe preventing the problems from getting so bad in the first place. And I think that that's been a cool thing that we've done.
Excellent. You may have to share some of those.
Yeah.
Now, now payback time, girl. Uh, how about any other tips about program development?
So I think program development wise, we all try to make sure that we're on the same page with each other. So I've made little kind of share drives that for my head and neck team, because I kind of lead our head and neck crew over in our clinic. So I'd be like, if you're doing an evaluation, we want to make sure we're all kind of checking these same boxes. And going over the same things and just that way when we go through and maybe a patient flips from one therapist to another because of scheduling availability, we're all kind of seeing the same stuff, taking the measurements the same way, because there's a lot of different ways you can do lymphedema measurements. You ideally want to be consistent with each other, and that way you can figure out the comparison between each other's measurements and each other's findings, rather than just having to figure out everything from scratch every time you switch to a new person. So I think consistency is the main thing when you're talking about program development, is not only just getting the patients in the first place by getting the physicians on board, which was kind of the handouts thing, but also making sure that everyone that's treating the same kind of groups of patients on your team, that they're all consistent with each other. You don't have to be doing identical things. You all have your own ideas, but consistent enough with each other that you can understand each other's work and work from it.
Great. That's very good. Yes, that's important. How about what it means to advocate for yourself and how can people do that? I preach that all the time to my patients. So
yes, I think advocating for yourself as a patient in its simplest form is trying to make yourself viewed as a person and not a data point. That's basically, you should feel informed about what's happening to your body, and you should feel like your medical team knows what's going on with how you're feeling. So I take that in those two different parts. So if you're not in a good place of understanding what the treatments are or what your cancer diagnosis is and everything like that, I think advocating yourself is being willing to ask the questions and continue, say, like, even if you don't know what to ask per se, saying, I don't feel like I understand this, can you explain it more? Or explain it in a different way, and see if you can get to a place where you feel like you understand what is going on with your body, because I think that's really, really important. And then on top of that, the second part being that the medical team that you have needs to hear from you about the side effects you're experiencing and how you're personally feeling about everything. So some people are a little afraid to communicate some of that. They feel like they're just complaining because, yeah, side effects are expected, but that's not the case. They want to, your physicians want to know what you are experiencing. It's really important, and I think it's good that they know what is going on with you, and you can ask, this is what's going on. I don't know if there's something that can be done to help it, but I at least want you to know about it. And oftentimes they will tell you that there is stuff that can be done to help those side effects. And they can't, unfortunately, give you that information unless they're aware that it's going on. So I think that advocating for yourself is two parts. One, be willing to ask for more explanation, and two, be willing to share how you're feeling.
that's true. And don't ever take everything that they tell you either. So if they tell you something that doesn't make sense, or something I tell patients is, again, we know that a lot of these secondary effects of the cancer treatments can be, for some people, they don't feel anything, and some people really feel really bad. So I always tell patients, everything is about quality of life, right? Because you may have medication or something you're doing, hopefully to avoid for that to come back or to treat the cancer. But in the other hand, you're feeling worse than ever, even
Yeah.
before your surgery. So do you really want to live like that? So I always tell patients, put on the balance, what is your quality of life look like? And is that what you want? And then you just need to bring that attention to the doctor and say, I understand this is the meds that I need to take, but I'm feeling this way. What kind of modifications we can do to these meds? And then usually the physicians will work with you about, decrease the dose or taking a break or changing the medications. Or sometimes you're just gonna have to make the decision of, you know what, I'm just rather just have a good quality of life. And if I have a recurrence, I'll deal with that at that point.
Yeah.
But sometimes I tell patients, you just don't just really, I say, you just kind of like hang in there for a few months and see what your body does. But if after a few months you're totally miserable, you have to have a heart-to-heart conversation with your physician and see what can be done. Because then it is no fun, right? If you're not having a good quality of life, then why doing all this?
Yeah,
So
I agree. I think that's huge. And I think people sometimes can get so lost and caught up in everything and doing the right thing. And I put that in quotation marks because it's like what they feel like they need to say yes all the time and just be a good patient. Yes, ideally, we do want to follow all of the best recommendations to treat the cancer, right? But quality of life is very, very important. And I think having those conversations about risks and benefits and understanding, what you're going through can help you make that decision with your medical team because you should be at least a part of the decision and what's going on.
exactly. Now we shift a little bit about your experience taking DPT students. So tell me a little bit about that.
So I've actually really enjoyed taking on the DPT students that I've had. I wanted to highlight what I think is the most exciting part. So it's obviously super, super fun to get them to understand the oncology world in and of itself. But on top of that, I think the most exciting part of taking on students is actually helping them build their confidence in what I call case management. So I think case management is probably one of the most difficult skills we have as PTs. Um, Honestly, probably a lot of other healthcare professions is sort of the same issue. But case management is just so hard. We're always trying to get better at it. Like I'm even still trying to get better at it. And I think probably the most senior therapists are still trying to get better at it. But it's really cool to see that switch when a student starts to get get it. So I find that in the oncology specialty, case management is particularly difficult for students in the beginning because there's sort of a lot of PT programs teach it as think about your discharge plan from the very first time you meet the patient. And I'm like, that's all fine and dandy, but
Reality is a reality.
patients change so much that that plan is like thrown out the window in 2 visits. It really doesn't work that way. So I instead kind of use the philosophy of try to think of what your patient needs right now to be more independent.
Good. I like that. Yeah.
So when you see them right now, what do they need to take better control over what's going on? What do they need? Is it they need to understand, how to control their lymphedema a little bit better at home? Is it that they need exercises to strengthen X, Y, and Z to stop that pain from coming back between their visits? Like you make it feel better, but then it pops right back. I think it's like, what do they need right then to help them be a little bit more independent? And if you go through that thought process every visit you see them, all the little puzzle pieces kind of start to fall in place, because
Yep.
when you meet a new issue, you have that same thought process and you kind of meet it where it's at, and keep stacking on things, and you're basically providing your patient with the tools in your toolbox, because really we want them to have it. And we also do need to know from a therapist standpoint, like some things just need to have surveillance from our eyes. You know, we have lymphedema surveillance, and things like that, where we might have them circle back in and check up with us. But the more tools you're providing your patients and teaching them honestly what you know, then you end up with a patient that is able to have a quality of life, and you're managing the case the best you can.
Yep, that's excellent. Yeah, it's a lot of like, I've been a CI for years and years and years, and it is so nice to see, um, yeah, they grow on a student, right? When they come in, and then just literally, I have two new students that start 2 days ago. And it is so neat to see, okay, on the first day, they're totally lost. And now today, each one of them did an eval. And it's like, that's great.
Yep.
Like you already know so much more in 2 days. And then again, to see their confidence building. And not only that, but my major satisfaction is when I have the students I used to have like you being, like I call it, is like just kind of extending all these fingers out in all over the place, where you guys have that, oncology passion, and then you continue training and passing on and building those skills for such a need in our career. So it's really great. And then here you go, having a guest on my podcast for somebody like you. I love it. So it's really fun. Um, how can people find you?
So I work full-time at Swedish Medical Center, Oncology Rehab out in Denver, Colorado. So if patient wants to find me, that's where you'll find me. I am not the most active person on social media, I'll admit, but if any clinicians or students or anybody like that wants to connect with me, I do have a LinkedIn account. There are a lot of Emily Bells, but if you find the physical therapist that works at Swedish, you can connect with me there too.
Perfect. And I will put the information on the show notes so people can have access to it. So is any one more question that you wish I will ask you and you have answered to wrap up?
Um, so one of the things I thought we should maybe highlight is kind of what a patient can expect from, let's say, like a pre-op or a prehab visit,
Good.
because I don't necessarily think all places across the country do it. And I think that's one of the things that a lot of patients are confused about, is when they don't actually have any issues yet.
Yep,
And they're like, why am I going to therapy?
that's an excellent point. Yes.
So I kind of wanted to highlight that a little bit. So a lot of times, if we're able to, and if the physicians are on board, we try to acquire our patients before they've actually started any cancer treatment. So they've got their diagnosis, they've got kind of their plan set in place roughly, but maybe haven't had their actual operation yet, or if they're not doing an operation, maybe they're going to do like chemotherapy or something like that. So we're trying to catch them like towards the beginning. And a lot of that is me trying to educate them on what to expect from a functional standpoint and a quality of life standpoint after what they're about to go through. So maybe I'm teaching them their surgeon's post-op precautions for like the 3 weeks after their surgery, or maybe I'm giving them a couple little gentle stretches that will help them feel better during that time frame, like right once they're out of the hospital. Maybe I'm talking about what the role of PT is going to be through what they're about to go through. And, maybe we're working on mitigating the development of lymphedema, or how bad it's going to be, or maybe we're talking about how they're going to keep their range of motion or manage their fatigue as they go through all of these treatments, and kind of what to expect. And then the big component of that visit is we need baseline data. It is so hard as a PT if we see someone and we notice that there is an actual like functional impairment. Like let's say you have reduced shoulder range of motion by 30 degrees overhead. How do I know like what came from what if
Yeah,
I didn't see you before the surgery happened? It's difficult to truly know like that limited neck range of motion or that size of your neck or your jaw function or anything like that unless I get baseline data. It's just really challenging. And if you're doing like lymphedema surveillance, it really helps to have baseline measurements so you can
yep,
compare, because sometimes the only other way is to compare limb to limb, and you might have a different size limb from the get-go. Um,
exactly. Yep,
from one side to another. So if we get baseline data and then we kind of educate the patient about what our role will be and some little tips and tricks about what they can do to maybe start feeling a little bit better. I think that that's sort of our role with the pre-op and the prehab. And a lot of patients seem to really appreciate it because they feel like they have a better understanding about what they're about to go into.
yeah. And then one other experience I have from that, because we do a lot of pre-op in the clinic as well, is the education really helped them to choose what is the best treatment for them after work. So
Yeah.
when they already, when you explain to them, like, for instance, head and neck cancer, which, is a very high, complex surgeries. And
Mhm.
then they've been on the ICU. Now they are ready to go home, and perhaps a lot of them end up with home health. But really, in the home health setting, very few therapies, if none, are going to help them with their head and neck lymphedema or the jaw function or their neck function.
Mhm.
It's going to be pretty much, let's make sure that you can walk from point A to point B, right? And then so these patients thinking for 3 weeks, 4 weeks, I need to have this home care before I can go into outpatient, but they're not really addressing any of my issues. So when we educate them prior to surgery, then they know what to expect because we've been telling them that, and they know like, no, I really don't need that. I need to go back and see the clinic, and because they know what they're doing. And then we can start then work on these patients prior to other treatments like radiation. So we're setting them up for much better outcomes versus
Mhm.
really not seeing them until they are already in radiation, or perhaps after radiation when things are just being more dysfunctional and more accumulation. So that really works really well.
Yeah, the more we can stay on top of things along the way,
Yeah,
usually the less bad you'll feel in the long run, right? Because we're kind of fighting it as it develops or as the problems accumulate. So things aren't just sitting there
yep,
bad for a really long time, because the more chronic an issue is, it's always the more undoing you have to do.
yep, yep, that is true. Well, we can continue going on and on and on for hours, but I know you have to go. That has been such a fun conversation. I think that that will just bring a lot of value to the audience. Just really, it's nice to hear from one of my colleagues, like, we kind of going on the same page, and then really continue promoting how important is our career in a cancer care for a patient, like how much rehab can do for you. So thanks, Emily, again. I really appreciate it.
You're welcome. It's been a pleasure. Thanks for inviting me.
Absolutely. You take care.
You too. Bye.